Good morning, everyone. It is truly an honor for me to be here with you today at this course, and I thank everyone for attending, Simon and Fatima for putting an outstanding program, and of course our ISUOG team who are behind the scenes making everything work. I am starting with the basic approach, the Every Little Heart Matters simplified approach to cardiac screening. I would like to declare that our ultrasound unit is a luminary site for GE. And over the next 30 minutes, what I hope to cover is first, the constituents of the ISUOG cardiac screening guidelines. How can we utilize a simplified sweep-based approach to accomplish this? How to recognize the normal planes and the hidden clues within. Now, congenital heart disease, as we know it, is the most common major abnormality, affecting approximately 1% of all babies globally. 30% have other associated abnormalities, and it contributes to more than 50% of congenital anomaly-related deaths of childhood. This is why it is so important for us to screen. 90% of infants are born to mothers without any risk factors, and this is why screening globally is so important and in adherence to guidelines. Now, we know that still we have suboptimal prenatal detection rates, and there are significant global disparities. And if we look at some of the data from the National Clearinghouse, it shows that detection rates can vary anywhere from 13 to 87%, depending on where you are in the world. We also know that there's ample evidence that socioeconomic factors play a role, depending on how far you are from a tertiary care center, where you are in the world, and this is a huge gap that we have yet to close. We know that with training and having guidelines, we can improve detection, and we know that prenatal detection will improve outcomes. And the latest data comes from the US, from the Annals of Thoracic Surgery, where they just looked at over 100,000 fetuses. And what they were able to show that in recent years, with the addition of the outflow tracts and the three-vessel trachea view, we have had a significant improvement in the prenatal detection rates. This is for the US since this has been accomplished. Of course, we're nowhere near perfect. This table here shows the various critical congenital heart defects, those that are amenable to detection by the four-chamber view, those that need the three-vessel trachea view, and you will see that we still have very low detection rates for some of these critical defects. So now, how do we screen for congenital heart defects? We have our ISUOG screening guideline that Professor Carvalho put, and it was updated back in 2023. And we know that we have to use a systematic approach that is based on transverse planes. And you will see me mention the transverse sweep, and I will highlight the importance of that. You have to start by establishing situs. You have to start at the abdominal circumference plane. And I highlight this point why? Because if none of us are screening for the heart yet, but we are obtaining biometry, you are technically obtaining that abdominal circumference plane. And the argument is, if you can obtain an abdominal circumference plane and you know where that fetal head is, and you slowly sweep up, you're going to be able to accomplish so much. And that takes training, of course, and pattern recognition as you look at more and more clips, but that is a great starting point. And so from there, as you sweep up, you will get to your four-chamber view. You'll see your left outflow tract first, your right outflow tract, and then you get to your three-vessel trachea view. And those are really the key planes in the ISUOG screening guideline. So it's much easier than you think, and that's what we're hoping with the Every Little Heart Matters campaign too, is to demystify cardiac screening. And those two clips I have from trainees in my ultrasound unit. One is a medical student, one is a sonography student, where I asked them, obtain the abdominal circumference plane and sweep slowly up. Of course, the fetus is in a great position in both of these, but look at this from a trainee who hasn't even gotten neither their medical medical degree nor their sonography boards. And if you do that very slowly, very purposefully, yes, obtaining it is one thing and seeing what's within the clip is another, but that is really the basis that we hope to impart. Now, angle of insonation is so important. You can ideally, we all love the apical approach when the fetus is lying on its back, but you may not be able to complete that. And the downside to this is a shadow dropout where you can have an erroneous VSD. You can approach it through the long axis view, and this is a right-sided approach. This is one of the great ways where your angle of insonation is at 90 degrees to the septum, and you can properly interrogate the septum for any VSDs. And of course, those of us who get a third trimester fetus, we are looking at the basal approach. This becomes very challenging later on in gestation with extensive shadowing, but sometimes that's all you're going to get. Now, preferred insonation is apically to right laterally. Optimization is key. We're going to see Professor Marr do his magic as he scans a fetus later on and how he really navigates through the machine. But you try to use a high-frequency probe, magnify your image, decrease your depth, narrow your sector width, and depending on the type of machine, you will do a lot of adjustments. Don't be scared to magnify. You need to have the fetal thorax occupy about 1/3 of the image. Use your harmonics, your compound resolution, your speckle reduction. Again, it depends on what machine you are using. High contrast is needed for the heart, and you need a high frame rate as well because it will really enhance the resolution. Insonate apically to right laterally, and I cannot overstate how important it is to use a cineclip. I personally cannot assess the heart from stills, as many of you in the audience, because you have to see the heart is the only organ that changes shape in systole and diastole. So without a clip, without being able to slow it down, understanding where am I in the cardiac cycle, what am I seeing, it becomes very limiting. Now, when you want to add color, it doesn't do its work on its own. You really have to have an optimal grayscale image first before you add on the color. You need to narrow your color box, select the type of color you are using based on how big or small the structure is. If I'm looking at the ventricles, I need very different settings than if I'm trying to look at the pulmonary veins. Adjust the velocity scale, adjust your wall filter, adjust your PRF, adjust your color persistence, adjust your color gain, adjust your color balance, and then you can start with the sweep. And so now we will start. First, you have to establish situs, and I cannot overstate how important this is. You cannot just look and say, I see the stomach, and this then must be the fetal left side. The first thing you have to do when you are establishing situs is you have to say, what position is this fetus in? And you see that on this image, I've left the sonographer's annotation that this was a breech fetus, because now you have to imagine how the fetal lie is in there. If this fetus is breech, I would expect its left side to be towards the maternal left, and here my stomach is on the maternal left side, then this is a correctly positioned stomach. And then as you sweep on up, you will see your cardiac axis is also leftward, so this is correct situs. And so in order to establish situs, you have to see what the fetal lie is, where the fetal spine is. Then you look at your abdominal circumference plane. You check, bisect it and see, is my aorta to the left? Is my SVC anterior and to the right? And then you sweep on up to the 4-chamber view. You will see a lot of checklist tables that will appear through the slides now, because these are some of the checklist items that as you sweep through from the stomach up to the 3VT, there are various things to look for and look through. And I have put here, I will not read through them, what you find in a normal heart, what you see in an abnormal heart, those you can review later. But here are 2 clips that I will play, and I hope that you can immediately recognize in both of these clips, though I have not labeled right and left, that the stomach and the cardiac axis are on opposite sides. And just with that very brief sweep, you can tell that what you're dealing with is situs ambiguous. Now we move on to the four-chamber view, which is a slide up from your abdominal circumference plane. And this is such an easy view to obtain. Anybody can obtain it if you can obtain an abdominal circumference plane. It does not require any specialized skill. It's an easy slide up, and it's obtainable in every single fetal position. Of course, shadowing and maternal characteristic limitations with BMI all play a significant role. You can rule out roughly 60% of congenital heart defects, and it is the starting point for the cardiac sweep. Now, for nomenclature, I think it's important to think of two things in general when you get to the four-chamber view, and they are cardiac position. Where is this heart in the chest with respect to the lungs and midline? Is it to the left as it should be? Is it to the right, or is it midline? And normally, if you have a change in position, think of a problem extrinsic to the heart. So usually it's either a diaphragmatic hernia, a CPAM, an absent lung, something outside the heart that has caused a shift in position. Versus the cardiac orientation, which is the axis, that should be levocardia, it could be meso, it could be dextro. Usually if there's a change in axis, then it is a problem intrinsic to the heart, outflow tract abnormalities, among others. Of course, you have a combination of both, but this is roughly a way that when I look at the chest and I see a change in position, first I think extrinsic. If I see a change in axis, then I think intrinsic to the heart. Now, I had an artist create this schematic because it is important to think through the cardiac cycle. There are different valves that open and close at different times. We have different connections. So remember always, systematic venous return comes back in a normal heart to the right atrium. The pulmonary venous return returns back to the left atrium. The right ventricle is more heavily trabeculated, and the left ventricle is the more cone-shaped, apex-forming ventricle. Now, no matter how complex the anomaly is, the valves are very loyal to their ventricles. So no matter the complexity, your tricuspid valve is always with the right ventricle. Your mitral valve is always with the left ventricle. And sometimes if you cannot identify the morphologic ventricle, but you can see the valves and see the offset, that may clue you in. Also look at where the outflow tracts are. Your pulmonary artery is the most anterior, and it is at a different level from the tricuspid valve. So here you can see that your tricuspid valve and your pulmonary artery are at different planes, in contrast to the left, where they are side by side. And this is why, when we're looking at the left side, a lot of times you see inflow through the mitral valve and outflow through the aorta side by side. So heart size and position, usually the heart, if you bisect the chest, it sits to the left of the chest with a third on the right and 2/3 on the left. You have an area, roughly a third of the chest, so you should be able to fit 3 hearts in that chest. You have a circumference that is half the circumference of the chest in general. And if you were to measure the cardiac axis, a very potent marker throughout gestation from the first trimester on, it's roughly 45 degrees. Of course, the heart is beating and it rotates as it beats, and there have been studies to show that the angle, whether you measure it in systole or diastole, varies, and this change between systole and diastole also changes if you have an underlying abnormality. There are many anatomic landmarks, and you can see the checklist at the level of the 4-chamber view is a lot more extensive. The left ventricle, as I mentioned, is the cone-shaped, apex-forming. The right is shorter, more trabeculated with the moderator band. You can see the aorta to the left of the spine, and next to it, about a third of the size, is the azygos. And I highlight this area. We call this the area behind the heart. We're going to talk a lot about it through the next 2 days. It can have so many clues there for you. And if you look as well, you will see that you have the offset of the valves. Moderator band is highlighted here, and this offset is very important at the level of the 4-chamber view. You see your pulmonary veins. These are the 2 inferior pulmonary veins coming into the left atrium, and usually your 4-chamber view is at the level of the 4th thoracic rib. Now, color is very important, and like I mentioned, it's very important to know, am I in systole or diastole? Because if you're going to interpret the direction of flow, if there's any regurgitation, you need to know where you are in the cardiac cycle. Now, the left atrium and the area behind the heart, as I mentioned, are very important. Within the left atrium, you have your septum primum, you have your septum secundum, you have the foramen ovale, and then here we managed to get both superior and inferior pulmonary veins on the right side. This is really angled. This is no longer your four-chamber view. At the level of the four-chamber view, you see the two inferior pulmonary veins. And of course, the descending aorta and the azygos, as I mentioned earlier. Now, the interventricular septum is important, but tricky to see, especially when we have an apical view, because you have this dropout. And this is because your angle of inclination is parallel, but is there really a defect there or not? Remember that the septum has two parts. It has a third part that we call the membranous part, and the lower two-thirds is the muscular part. And with the checklist for the four-chamber view, there is so much that you can check for at each level in normal and abnormal hearts. So here are some examples that I hope you will be able to see. In this first example, I hope you can notice there is ventricular disproportion, with the left side is much smaller. This was a case of a coarctation. In this next clip here, you will see that there is an apical displacement of the septal leaflets of the tricuspid valve in Epstein's. And in this case, you will see I've labeled right and left. There is no flow through the mitral valve. There's almost a single ventricle morphology in a hypoplastic left, in contrast to here, where there's no flow across the tricuspid valve in tricuspid atresia. And this very last case, you will see that there seems to be a very narrow left ventricle. There is a vessel behind the atria. This was total anomalous pulmonary venous return. So now we move up, and the first view that will come up slowly as you sweep is the left ventricular outflow tract, and this is where we need to pause next. And so remember, as I mentioned, that what is unique to the left ventricle is you see the inflow and the outflow simultaneously at the same time. And when you put colors, sometimes you see a lot of red and blue. So if you're just starting and you're not used to this is not regurgitation. This is normal because you're catching the outflow and the inflow simultaneously. But with the left ventricular outflow tract, it is so important to see that it's coming from the left ventricle only, that it is exiting out at an angle, and you have this continuity medially. And it needs to not bifurcate, because sometimes it becomes very hard to see whether there is a bifurcation or not. You need to follow that ventricle all the way out, or otherwise you may miss transposition. And here are some examples. This first one, I hope you can see that there's an override in a tetralogy of Fallot. In the second one, you will see one huge exiting large vessel that has branching, and this was a common arterial trunk. In this case here, you will see that the two vessels exiting are parallel to each other, and if you follow them, the one exiting from the anterior right ventricle does not bifurcate, and this is transposition. And in this very last case, you see two vessels exiting side by side from the anterior right ventricle, and this is a double outlet right ventricle. Now, your right ventricular outflow tract is next, and this is more challenging to get because remember, this is going to give you three branches. What you are going to get you're going to get your right and left branch pulmonary arteries, and then you're going to have your ductus arteriosus continue on up. And these planes are very close to each other. If you're not very slow, you will miss them. You have to angle in order to get the branch pulmonary arteries. The left branch tends to be the most challenging to get. But when you look at your right outflow tract, you need to make sure it exits from the right ventricle. You need to make sure it is anterior to your LVOT. You have to see that it is bifurcating, and you will see your ductus arteriosus coming straight into your descending aorta. And this is another example here where you can see with color as well, and you can see the bifurcation in the middle clip of the two branch pulmonary arteries. There is a long checklist, and these are similar to the cases I just showed you for the LVOT as you come out to your outflows. In this first case here, you see the outflow, the override, and you really do not see except a very small, narrow main pulmonary artery. And this is a case of tetralogy of Fallot. We're going to have full top lectures on all of these anomalies, so you will get a lot more information on them. And in this case, this is the common arterial trunk as well. And here you have transposition again with two side-by-side vessels and the double outlet right ventricle. So next is the three-vessel trachea view on our way up, a most critical view that will be highlighted throughout the program today and tomorrow. And when I talk about vascular rings, I will be talking a lot about the 3VT, a very easy to obtain, even in the first trimester with color, just by continuing the sweep from your four-chamber view. But this is where you see your ductal arch, your transverse aortic arch, and the superior vena cava merging in the shape of a V to the left side of the spine and to the left of the trachea as well. And you have the perfect V. What you need to see here is the number of vessels. We should see 3 vessels. You need to look at their size. They should be about equal in size, the transverse arches. You need to see the direction of flow in them. It should be the same towards the spine, and you should have also their orientation with respect to the trachea is very important. And here are, as we sweep up from the four-chamber view straight to the 3VT, in the first case, you see a narrowed isthmus, reversal of flow, and a case of coarctation. In the second case here, you see the parallel vessels, and as you go up to the 3VT, you get 2 instead of 3 vessels. And in this case here, you have a single filling chamber, and again, 2 vessels at the 3VT, and a case of a hypoplast. And in this last case, this is at the 3VT, you have very narrow isthmus, you have reversal of flow from the ductal arch, and this was aortic stenosis. And the last one is a still image. I hope you can see 4 vessels there. This has the collecting vessel in that case of TA-PVR. So with that overview, what are the congenital heart defects not to be missed? And the focus for us in the Every Little Heart Matters campaign is the critical congenital heart defects. Though you may not be able to recognize what the final abnormality is recognizing that the heart is abnormal for referral. But what are the critical congenital heart defects? These are the ones that if they are missed, they will lead to significant mortality and morbidity. And if they are not recognized immediately after birth, we may have acute cardiovascular collapse and death. These are specific lesions that are well established, and here is a list of them. It is the hypoplastic left, coarctation, aortic stenosis, tetralogy of Fallot, detransposition, double outlet right ventricle, persistent truncus, interrupted aortic arch, pulmonary atresia, tricuspid atresia, single ventricle, TA-PVR, and Epstein's. And again, there will be ample time to have in-depth reviews of all of these critical congenital heart defects in the coming 2 days. Now, with that in mind, what are some of the sonographic clues for diagnosis? This is just a table that has the critical congenital heart defects. It highlights where the clues are at the four-chamber view, at the 3-vessel trachea view, and of course, the outflow tracts are very important. If you are not comfortable getting the outflow tracts, you have sufficient clues from just 4-chamber and 3-vessel trachea view. Next, where are we going in the future? Well, there's a lot that's being done in the first trimester, and Professor Mar will give us a stunning presentation on the first trimester heart. But basically, we do have our first trimester guidelines, and in addition to the ISUOG screening cardiac guideline, we highlight the importance of situs, of getting your 4-chamber view without and with color, establishing the cardiac axis, which is very simple to measure. This was described by Sinkoviskaya many years ago, and it is one of the most potent markers for diagnosing isolated heart defects in the first trimester. It does outperform both the nuchal and tricuspid and ductus venosus combined together. And finally, the three-vessel trachea view, which is not that difficult to get in the first trimester. Together, getting a 4-chamber and a three-vessel trachea view helps you rule out more than 80% of major congenital heart defects. And you are able to diagnose many anomalies in the first trimester. Of course, AI, why are we talking and dedicating 2 days for the heart with AI? There is so much coming out, but still, if you don't have the understanding of how to obtain the image, how to optimize it, how to interpret it, and you're not going to be able to utilize AI properly. At least for now, I think we will need all of our capabilities in the coming 5 years, but the world is moving very quickly, and there is a lot that is out there already about software that you connect to your machine that can pull out these planes for you, and it's available from various providers. So to conclude, I hope I've been able to show you that it is easy to screen for congenital heart defects, starting with the abdominal circumference plane and coming out to the three-vessel trachea view. Using a standardized checklist in your mind, you can look for many markers that will help improve your diagnosis. I have 4 clips here that I hope you can look at to decide which one is abnormal. I know they're playing fast and they are all simultaneous, but if you look very carefully all the way up to the 3VT, you will see that the first 3 are normal and the last is abnormal with transposition. It is possible to detect many major abnormalities. The critical congenital heart defects can be detected. Again, the focus of our campaign is not for you to reach the final diagnosis, but to recognize that something is not right and refer the patient. So cardiac screening is feasible. The cardiac sweep, starting at the abdominal circumference plane, is achievable. It's key to recognize when the heart is abnormal, and we have a 14-point simplified checklist for ELHM. More will be coming out on this. We hope to have an app out soon for you with a lot of more educational content. And I thank my amazing team of sonographers at the University of Florida, without whom none of this is possible. This is the QR code for the page for ELHM, and I thank you for your attention.